Good evening, and thank you for attending AACP's webinar with Julia Worrall, presenting Incorporating Quantified Postural Assessments into Your Practice. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. This webinar is approximately 50 minutes in length, followed by a 10-minute Q&A session. Please enter any questions you have in the Q&A box at the bottom of your Zoom screen, and we will address them at the end of the presentation. The AACP has no conflicts of interest. Registrants can expect to receive a recording of the presentation via email within 10 to 14 business days, and members of the AACP attending live will receive their CE certificate attendance within 30 days of the webinar air date. Register today for live advanced injections, PRF, prolotherapy, PBM laser therapies, and osteopathic manipulative treatment course, April 19th through 20th in South Bend, Indiana. The course will be a hybrid of pre-course virtual review and heavy hands-on techniques for injections, drawing blood, and osteopathic manipulative treatment. It will build upon previous coursework in injections, anatomy, and adjunctive therapies for patients suffering from craniofacial pain. You can register at aacfp.org or scan the QR code at the bottom of this slide to be directed to the registration page. Also, be sure to mark your calendars for AACP's 39th Annual Symposium at the University of Notre Dame on October 25th through 26th. Registration opens April 16th. I would like to introduce our speaker tonight, Julia Worrall. Julia, known as the Sleep RN, has made groundbreaking advancements in patient care. Her focus on the intersection of human physiology and precise quantified assessments has elevated the standards of care. Her functional approach to sleep and pain conditions goes beyond traditional treatments, championing holistic strategies. Emphasizing the critical role of sleep in healing and pain management, her innovative methods have transformed the lives of many patients, offering a more profound understanding and effective handling of their conditions through alternative and regenerative therapies. And with that, I would like to turn it over to Julia.
Thank you so much, Shaylin, and it is a pleasure to be here tonight with all of you from AACP. And I am happy to present on incorporating quantified postural assessments into your practice. No doubt, many of you are doing some form of postural assessment if you are in the world of sleep and TMD. And I have for years as well. But I did find that there were some challenges in getting the patient to see and understand what I was seeing. And this new method of assessing posture provides quantified data, we'll talk about that, and a visual aid for your client to now see what you see. So it changes the game in terms of case acceptance and moving forward and empowering your patient to be your partner in your care. It is really game changing. So it's exciting new technology, and the world of AI, of course, is leading the way in so many areas, and we're happy to be a part of that. Did you know, you probably do, that 75% of adults suffer from various forms of postural dysfunctions contributing to TMJ disorders. So imagine if the way that you sit or stand or even sleep could be the hidden root of that nagging jaw pain. So when I do this presentation to the medical community, I am advocating for them to recognize the role that posture plays on the head, neck, and jaw area, and especially for TMJ issues and for sleep. Because in my background in the medical field, I've often found that the medical community just does not understand the connection whatsoever. And I came to this world through my own experience. So as a nurse in critical care for many years, I suffered from sleep apnea, which it took a long time to find out that that was the issue. And I had migraines, intractable migraines. And I was in the medical community. And so I had access to any provider that I wanted, and I still could not get any resolution. And I was taking several medications, and I was always exhausted. And it was a dentist that actually helped me to understand the root cause of my headaches and my sleep problems. And from that, it launched me on a journey of learning as much as I could. And so I'm always very grateful to the AACP because it gave me my footing in the world of sleep and craniofacial pain in teaching me the missing parts of my education and the medical field in general. So it provided the missing pieces of if if we have all this knowledge about the patient and we've done the labs and we've done the neurological exam and we've done everything that we've been trained to do, and yet we still can't help the patient, what's missing? And my whole career in the last decade has shifted to try to bridge the medical dental gap, to help the medical community to understand the missing piece is what you provide, is the dental part of it, and understanding that connection. And then also to help the dental community to understand that they actually have so much more power than I think that you realize, because there are so many conditions that you can help with by understanding intimately the role of the trigeminal complex. So we're going to talk about some of those things tonight, and I'm always very eager to collaborate in any way that I can and to support you in any way that I can in your community, because I see the numbers of people that are suffering needlessly because of a science practice gap or because of the politics between the two different groups, which is ridiculous. In the last few years, I have taken that and I have gone into more of the regenerative medicine cellular therapies. And because I wasn't able to really do that freely in Canada or United States, I now live in Mexico. I have a practice here, and we incorporate the whole thing, the body, the mouth, the jaw, the sleep testing, and we're able to use stem cells, exosomes, secretomas. We're able to use all sorts of things to regenerate the areas that we once thought were broken down for good. So it's amazing to see the transformations that we can create in people. This is my office and my assistant, and this is the postural scanner that I use. It's about 6 feet long. You need about 3 feet wide. The mat rolls up like a yoga mat, so it's very streamlined. And you basically have the patient stand with their feet facing the front on the red line. It does a scan. They turn to the right. They turn to the back. They bend over, touch their knees. It's done. The whole thing takes 1 minute. That's the static assessment. We also have a dynamic assessment that it does where you have the patient do 5 squats to see if the nervous system, the muscles, and the skeleton are working in coherence together. And then we have a test where it's a one-legged stand to check proprioception and balance. And that's especially vital in people as they age. They don't realize that. And every single time I find a patient that cannot maintain at least 30 seconds of one-legged standing, inevitably what you find is they're either tongue-tied, low resting tongue posture, they've worn down their back teeth, or they don't have any support. But there's always an issue with the jaw or loss of vertical dimension. So before I would know that, and I would say that to my client, and they just could not understand how not being able to maintain a one-legged stand would in any way be related to their jaw or their teeth or their tongue. So this has really opened up the door now for me to have much more effective conversations with my patients. So today we're going to talk about the connection between the impact of TMJ disorders and the implication on sleep and the relationship between structure, sleep, and pain. And I want to help you to understand that when you're looking at the jaw, Don't want you to just look at the jaw. Step back and take a look at the whole person because it's all connected. And the third thing is to provide some practical knowledge and tips for you to incorporate these things into your dental practice. So the intersection between posture and oral health, putting the body back together again. At some point along the way, somebody decided to separate out different sections of the body and create specialties. And it seemed like a good idea because then you could focus really, really well on one topic and get really good at that. Except that nowhere along the way has anybody sat down and figured out how to bring all those people back together to help the whole patient. So many times patients will run from one provider to another provider getting partial solutions and yet never get a full resolution of their symptoms because it's piecemeal. And the one provider doesn't speak to the other provider, and the patient doesn't know what information is vital for the providers to know. So that's a challenge. And I really think that developing the relationship between medicine and dentistry is a really good start to that, and working with different body workers and not underestimating the value of some of the body workers, so physiotherapy, chiropractor, osteopath, helping to build out that network. So one of the frustrating things that I see, and no doubt you experience this too, is that somebody will have a neck issue, let's say back pain, and will go to a physiotherapist, and the physiotherapist works on the muscles. And even in the dental community, you may have myofunctional therapists that work on the muscles and teaching exercises for the patient to do. And all the exercises are all designed to help the patient to strengthen the muscle, tone the muscle, teach the muscle. But when it comes to posture, posture is neurologically mediated. So it is a neurological issue, and it's a constant feedback between the information being received by the brain from the feet and from the eyes, and trying to keep the body, the eyes, the hips, the shoulders, everything parallel to the ground when standing. It's neurological. So even a parent constantly telling the child to stand up straight, sit up straight, stop slouching. So because it's neurologically driven and the nerves talk to the muscles, focusing on the muscles is kind of like one step too late. So looking at the neurological influence on the muscles helps us to understand why people may have certain issues. And some of the information I'm presenting to you tonight, I'm going to give full credit to the people who have helped me to fill in gaps in my knowledge. And part of that would be probably Lois Laney, and taking my neurological assessment that I learned and adding the cranial nerve guru that she is, all of that information to it to just take it to another level. And here in Mexico, I happen to be neighbors with Dr. Kay MacArthur and Robert Walker, and this is kind of all they do, is talk about these types of things. So they've been a really great influence in helping to really expand my view on the implications of postural distortions. And when we're talking about postural distortions, what we're looking at is, basically the head, the torso, and the pelvis, how they communicate together, and are they level, parallel with the ground when the person is walking. And if not, if one of them starts to shift, what we see is compensations. So corresponding compensations that will pull on the skeletal structure, changing the nature of that person's posture. So understanding how they all fit together, we're going to talk a little bit about ascending issues and descending issues, and then how can we incorporate this into our practice in a meaningful way. So structural integrity, what we're looking for is structure and function. When I worked in the emergency room in trauma, one of the first things we did when a person came in is, whether they could communicate or not, is we patted down the body, and what we were feeling for was any distortions, asymmetries, anything that wasn't where it should be. And if it wasn't where it should be, we would pop it back in. You have to put it back into alignment in order to maintain that integrity. If you didn't, you were at risk of nerves being pinched, blood flow being diminished, lymphatic drainage being diminished, and swelling increasing. And it could lead to loss of the limb. So the flow underneath, we have muscles, we have nerves, and we have the skeletal system. And then looking at the flow of what needs to be communicating underneath, structural integrity becomes really important. The neuromuscular pull on these bones, right? So nerves to muscle, the muscle pulls on the bone. And if it's pulling in an improper way, you can get imbalances and asymmetries. So when we're looking at the face in the dental industry, we are observing any type of asymmetry in the face. Take a step back and look lower. We're looking at the shoulders. Are they asymmetrical? Are the hips, the knees, the feet? So it all has, should be cohesive for many reasons. If they're not cohesive, and if there is not symmetry, which our body just loves to have symmetry, then we end up with pain syndromes. I was flying probably to an AACP conference one time, and I was sitting beside a gentleman and asking him where he was going, what he was doing. And he was the doctor that invented this surgery for trigeminal neuralgia, and he was retired, but he was traveling around the world teaching his technique. So we had a really good conversation about trigeminal neuralgia. And he was expressing that it was, you know, the nerve being pinched with the blood vessel, and that they would go up through the nose, and then they would just relieve that pressure on the nerve. And I asked him, well, what about the skeletal structure underneath, the cranial structure? Could it be that the jaw is out of alignment or shifted, and that has caused the tissue, the blood vessels, and everything to shift also and pinch against the nerve? And if you just took the jaw and made sure that it was in the proper place, and those cranial bones make sure that they're where they should be, then shouldn't there be enough room for the blood vessel and the nerve to pass freely? And he didn't say anything for a minute. He was just kind of like visualizing it. And then I just kind of put his hand over his face and said, well, you know what? Very well, maybe. He goes, but I've kind of created my whole career out of what I do. So I'm not about to change that now. But I mean, I think that we all agree here that lack of understanding of how it all fits together can create, yes, not only pain and pain syndromes that are completely debilitating for people, but also a lot of unnecessary treatments, a lot of cost, emotionally, spiritually, physically. It costs our patients a lot for us not to be aware of these connections. So let's talk for a little bit about descending patterns, because that's where we tend to start from, right? So looking at neuromuscular deterioration of the head, neck, or jaw muscles, what do people inevitably end up experiencing in that area is headaches. So they will come to us many times for a variety of headaches. And yes, there are other reasons why somebody may get headaches. It may be that women around the time of their cycle may tend to get more headaches. There's a change in their estrogen and the muscles relax, the ligaments relax, and so they are a little bit more unstable during that time. There are various reasons why people get headaches. However, I've rarely seen somebody who has a history of chronic headaches who doesn't also have some sort of craniofacial distortion. And when it comes to scoliosis, so I don't know about you, but I remember in school, they would come around, they make you bend over, and they would check you for scoliosis when you were in school. Why did they do that? Why did they make that special effort to do that? Well, because they knew that if they left it and you grew up and you had this curvature in your back, it would compress it could compress one of your lungs, it could compress the kidneys, it could compress your bowels. And so the organs underneath your rib cage and your spine would be compromised because the curvature of the back. So they didn't want that. They were very proactive. But rarely do people stop to think about the asymmetry or facial scoliosis that we see on people where they have complete asymmetry, or whether their bones and from all angles, right? So I get a patient to tilt their head back so I can take a picture this way to look to see if their cheeks are equal. You know, you're looking at their eyes, their ears, their nose, their labial folds. So you're looking at all these things to assess whether they're equal or not, because underneath is vital anatomy. We have our cranial nerves, we have blood flow, many lymph glands, the lymphatic system, and of course our brain. And if you've been following the Brain Initiative over the last several years, where yes, they did a big mapping of the brain. Then the next phase was the functional assessment of what each of those things do in the brain. And then recently they came out and they said, you know, what actually matters more than all of that is the shape of the cranium that holds the brain in it, that there's enough fluid to cushion all the way around and that we don't have any part of the cranium pressing in against the brain. So the thought is that when you get to a certain age, though, there's nothing more that you can do about that the sutures are fused and the patient, it's a hopeless case. And you and I know that those sutures are not completely fused, that over time, gentle pressure, that you can adjust those. And there are some chiropractors and osteopaths that are very adept at shifting and gently moving those. We're only talking millimeters, or which makes a huge difference neurologically speak. So headaches, primary reason people come. The other thing is neck pain. So when we're talking about neck pain and the impact that it has structurally, the fact is that if the patient already has an issue with their neck and is playing sports, is much more likely to be at risk for concussion. Because if the neck doesn't have the proper curvature, then it doesn't provide the same type of cushioning to the brain that a proper curve in the neck would allow. If the jaw is not in the right position, that also has an effect. And you get this, we always talk about coup contra coup, you know, this the brain kind of bouncing in the cranium, and that's why people get concussion. But what about the fact that you have the jaw going into a hyperextension against the motion of the head and against the motion of the neck? People have more issues from that than have actual concussions. So 70% of the people that are having post-concussive symptoms are actually experiencing this neuromuscular kind of firing that happens at the junction of their trigeminal joint. So in the world of jaw and TMJ pain, I don't need to go into all of the definitions and what it is that you see in your office, because this is kind of what you do all day long. But suffice it to say that in our assessments of the posture, if we are not looking at distortions that come from the feet up, so the arch falls and then the knees roll in and everything rolls in, or you get a pelvis that is elevated on one side, that creates a twisting. So the shoulder drops down and then you get a twisting of the body that happens, and it ends up at the jaw. So fixating on the jaw and trying to get the jaw aligned is very helpful for solving some of these descending problems. But if the body is still twisted and not in alignment, then that patient will not get complete resolution. And they may be coming to you saying, I'm still having pain, I'm still having pain. And it's not that you didn't do everything that you know how to do for the jaw. And you may even test and get the jaw into the proper balance, and you use your machines and make sure the muscles are calm and the muscles are happy there. But then the patient gets up and walks away and they're still having issues. So this is where having something that allows you to look at what are you missing and look at the whole body really helps you with these cases to get better resolution of their symptoms. The central nervous system, so posturally, when we think about even forward head posture, which is very common. We have forward head posture, it pulls on the dura mater and it causes this spinal impact that causes all sorts of symptoms, whether it's digestion, it's shoulder pain, it's limited range of motion in the arms, thoracic outlet syndrome, all these things. And for doctors, having these patients come in with these issues, they're going to fixate on that point, on the pain point the patient has. And ideally, helping them to look beyond that, above and below, because wherever the distortion is, you're going to have problems above and below, right? So think about the patients think about the people that don't understand that a lot of these issues that they have, you could actually be helping them with. And I mean, as a nurse, I'm going to say this, but you could be relieving a lot of pressure that's on the medical system right now, where patients can't find doctors, they can't find help, and there are conditions that they have are related to the jaw, and being able to understand that connection. Anyways, you could help a lot of people. So ascending patterns. We talk about ascending patterns, we're talking from the feet up. And why is that so important? Because it's basically the heel of the foot that is controlling posture, upright posture. So trying to hold yourself up against gravity, walking is such an amazing feat that we can walk on 2 feet. If we can walk on 2 feet, that is amazing in itself. Everything that needs to happen for us to be able to walk on 2 feet. And it starts from the heel of the ground, at the heel and how it strikes the ground, and the front of the foot and how mobile it is. So when we do our assessments, we are going to take a look at the feet and see if there's overpronation of the feet, because if there is, you're never going to get true postural correction until you resolve that issue. So from the ground up, from the head down. And if the feet are overpronated, internally or externally, then where the femur is going to strike on the fibia and tibia, on the tibia weight bearing, is going to change. So what we see a lot of times in my practice is patients that come for stem cells. They want stem cells in their knees, or they've had knee replacements. And the fact of the matter is that if you don't create the problem that caused it, then it's a poor investment for them to do that. So by getting the structure aligned first, and then regrowing some of that cartilage and tissue that has deteriorated over time, is game-changing for a lot of these people, and they can put off having a knee replacement either for another 5 to 10 years or indefinitely if they manage it properly. At the end of the day, where does it all converge? So the descending patterns converge and ascending at the pelvis. If the pelvis is off, then you're never going to get postural stability. And the pelvis is closely correlated to the jaw. So if the jaw is coming forward, the pelvis has to change in order to accommodate the weight of that forward flexion. And what you have is the thorax ends up going back and the pelvis ends up rotating anteriorly, and you end up having forward head posture. So the compensations that happen from this can create sciatica. So think about, I've often actually thought about sciatica pain is comparable to trigeminal nerve pain. So with sciatica, you've got the pelvis rotated, the hips are off, and that little bit of a twist pinches the nerve. and you get intense shooting pain that radiates down your butt and your leg. And trigeminal neuralgia is very similar. You have a impingement on the nerve that causes excruciating pain. And I'm hoping as time goes on, these connections will be made clearer so that it's the first things we look at instead of patients having to spend years trying to navigate the system to find out what is wrong with them. And I know even as a nurse, I mean, I often had back pain and they would be focused on my SI joints and low back, and it was all about that. And I remember saying, I feel like it's higher up. I feel like it's my neck. No, it's and it wasn't until I started actually getting treatment on my jaw and started to unravel things that then actually, in some cases, you get more pain. You get more pain at the beginning because now those bones that have been used to being a certain way, now you're putting them in a different position, and the muscles have to accommodate that, which can be uncomfortable until the whole nervous system then settles down and realizes its new place. So those patients that come to you, what are they going to come to you with? They're going to come with tension type of headaches, complaining of TMJ, post-traumatic headaches, neck pain, migraines, jaw clenching, bruxism, and inevitably we're going to screen for sleep disorders, right? Because we know that these syndromes are all linked, and that if a patient is experiencing these pain syndromes, there's a pretty good chance that they are not sleeping well. And there have been studies done that show that poor sleep is an independent factor contributing to an increase of sensation of pain. So, you know, this chicken and egg thing, which comes first, poor sleep or the chronic back and neck pain? Well, the research says poor sleep, actually. It makes you less resilient and you feel pain more sensitively. And then when you don't get sleep, you're not able to handle the pain as well, and the nervous system responds. And so you're just in this whole loop. So if you're not screening for sleep disorders yet, I would strongly encourage you to do so, because sleep is an entire different physiology that your body goes through all night. And most people think it's just closing your eyes. And that is why so many people are suffering from depression and anxiety and living high-risk behaviors and all of those things, and especially our adolescents. And I'm going to share a case study with you of a teenager that I saw and how all of this comes together. So what is quantified postural assessments? Well, I don't know what you're using, if you're using anything in your practice, but for a long time I used a grid and took pictures of my patients. And I said, well, I see that you're up here. Do you notice that you're up here, you're higher here? And granted, I'm not a physiotherapist, osteopath. I'm not trained to be able to do these full head to body examinations, which normally take probably about half an hour, maybe 45 minutes for somebody who spent years training and learning how to do this. And I'm not replacing them. I will identify issues and then send them to somebody to deal with that. So I'm just gathering the data because this is going to help me help my patient. But what I love about this new way of doing it is that we can actually see the numbers, and we can measure, and we can score on an A, B, C, or D, and it gives a percentage of where the body is off. So like in this picture, you know, the clavicle is up 3 degrees, the pelvis is rotated and elevated, and the knees also, we have a number so that we can track the patient's progress. So if I do this to you and then I scan you again, do we see improvement? And it helps the patient remain engaged and follow through on the protocol. And it helps you to also validate that what you're doing is having an effect, having the desired effect. So quantified, the being able to have it done quickly, it's non-invasive. I don't have to send my patient for an x-ray, which exposes them to radiation. I don't have to put them on a wait list to try to get an MRI or a CT scan. I can right in my office, right then and there, do a scan and be able to visually see where the issues are and start a plan. And of course, this is all non-traumatic we're looking at, right? So obviously, if something was traumatic, they had a car accident or they had a fall, obviously, then you'd want to get imaging. But you don't need to get imaging on everybody. And in fact, the emergency room guidelines, they don't do imaging on everybody, hardly anybody. So if you come in with back pain, you're not getting anything unless you say that you fell 6 feet or more, or you were in a car accident, greater than, I think, 15 miles an hour. So this actually provides an instant way to get the data that you need and to reassure your patient. So like I said, this is the scanner that I use, very streamlined, and it provides information on the muscles. So when I see the muscles are blue, it means that they could be strengthened. When I see the muscles are red, it means that they're tight and they need to be stretched. And so we're looking for those imbalances. And you're always going to see that if the one side is weaker, the other side is compensating. If that other side is compensating and is tight, then what is it doing to the skeleton? It's pulling on the skeleton. So you'll see that the skeleton on that side tends to be elevated or shifted, and on the bluer side, it's a little bit weaker. So now we can start to understand or help the patient understand how to target their exercise, how to target their training. In the athletic world, it allows the trainers to work more specifically with the athletes to actually train for coherence and balance on both sides and reduce injuries. The skeletal system, it allows us to look for scoliosis, and we can separate out the spine and see what is happening there. And then it allows us to then take it and look at what is normal, what you should be, and where are you right now. And all of that is very helpful for the client to understand. When we do this scan, the patient automatically gets a report emailed to them, and it comes with 4 weeks of exercises. So 4 exercises each week for 4 weeks to help balance the structure, their structure. And these are a couple examples of the reports that they will get. So I'm just going to share this experience with you. Riley John is not his real name. He's given me permission to share these. He's a 20-year-old, and he is like every typical teenager, young adult. His parents would be frustrated. He'd be up all night playing video games, sleeping all day, didn't want to work, depressed. Parents didn't know what to do with him. He didn't shower. He came into my office and he hadn't showered, I could tell, in a very long time, and didn't make eye contact. And the parents brought him down because he was going to have surgery done. They said he had scoliosis and he had degeneration in the lumbar area, and they were going to put a rod in to straighten out his back. So they asked us to see him because they wanted stem cells put in first. So I said, before we do that, why don't we have a look and do a scan and see what's going on? So this young guy had 18-degree forward head posture, and that's probably one of the highest that I've seen. Additionally, when he walked in, he couldn't put his right leg down on the ground flat. So he walked tippy-toe on the right leg, flat-footed on the left, and he had severe pain getting up from the chair and moving and trying to come up the stairs. He was just in severe pain. We looked at his pelvis, and it was rotated forward 4 degrees and up 3 degrees. And when we looked at his results, so you can manipulate the data, you can move it around, it's 3D. This is his neck. So the areas in red show an area of concern, and he's 97.6%. That is his issue, that forward head posture. That's how he should be. And this is how he is. And when we look at the muscles, what we see is the muscles start to shut down, right? So you have imbalance. If we look at deep in the muscle right in front of his neck, longest, I can't remember at this moment, but anyways, that muscle shuts down. And so that is the muscle right behind our throat. So what do you think happens to this boy when he's sleeping and those muscles they've shut off because they're not getting good flow? And additionally, as that head comes forward, it's the hyoid is pulling on the C2, C3, so you're getting a compression of the airway. And I'll show you more about that in a second, but I want you to keep that in mind. So then we look at his pelvis. So the head going forward, remember, it's always a compensation for the pelvis being off. This is how proper posture should be. And this is how he is now. So shifted, pelvis is up and forward. And that is where all his pain was, right in there. The lumbar spine to the sacrum is where everything was compressed. It was 80% compressed. And they thought the only solution would be for him to have surgery to get him aligned. And we look, of course, at his feet. So before we can correct his posture, I need to know, is he overpronated? Yes, he is. So that is impacting the angle at which his tibia is striking his knee. So now we know the areas that we have to look at. And this is the report that he gets, and the report also gives ideas of how to avoid it. So, for example, it says basically to the posterior pelvic shift, if you've been slouched position for a long time with your hips pulled back, it could contribute to that. So they start to have ideas of how to work on these things at home. So this is after, I want to say 3 months, 3.5 months. So working with an SOT chiropractor, he is now 10 degrees forward, not 18, but that's already made a significant difference. We still would like to get him a little bit more. He's working on that, but it's definitely improved. And if you look at the muscles, we don't see the same degree of muscular imbalance, but he still needs to strengthen the muscle for his neck. And the back has improved, but you know, again, it's with a young person, it's maintaining and getting him to do the exercises. But I will say that by this point, he is now working 2 jobs and also has a girlfriend. So his life changed in 4 months incredibly because we were able to get his foot flat on the ground. Look at his back. I mean, his pelvis now is barely an issue for him. The back pain that he had, the debilitating back pain, resolved, and we were able to put stem cells in there now to regenerate some of that area. And he did not, so now he's not getting surgery. He doesn't have to have surgery. So that is an excellent example of just, you know, a young person, you wouldn't necessarily think that they had so many postural distortions, but if it was left untreated, this person would be in for a lifetime of pain and probably end up on painkillers and opiates and just really not accomplish much in life. And now he has his life back. But remember, I talked about the forward head posture and the impact that it has on the airway. So what I did from, this is before and after, he was 90%, he went to 58% from 18 degrees to 10. What I did is combine the knowledge of everything together and knowing that if the structure is off and the airway is going to be compromised, what is the next step that we need to do? So immediately, I used this device in our clinic and we did sleep testing on him. Sleep testing is critical for so many reasons. And I know if you're with the AACP, that this is one thing that you will definitely hear a lot about. And my friend Deepak Srivastava, who's been an amazing mentor to me and helps me down there and with these cases, has just been, it's been mind-blowing to think about how much the medical community misses because we don't understand sleep, which is so bizarre to me that we never learned those things in school. So whatever you can learn about sleep and bringing that into the conversation and asking people about it, this really helps me to have that conversation. So the first ones we did, if you notice, his oxygen saturation was 84%. He's got a little bit of clenching and grinding going on. He's got snoring, definitely. And this was the very first night after we did his first scan. So then the second night, he dropped down to 71%. And I was concerned, but he took it off partway through the night. And I thought, okay, well, we're going to do another night and see what's going on. I was a little bit concerned that his heart rate went up to 133. And then we do the next night, he goes to 85%. But if you look at his heart rate jumped to 236. So that is, you have a pacer on your heart, like it should never get to that level. So the fact that it's getting to that level tells me that pacer is not working. And this kid is at high risk for a heart attack and dying in his sleep. And he's 20 years old. So I called the family to come in immediately. That same day, we got him on a CPAP while we could figure out all of this other stuff and work through those issues. And the changes to this boy from the combination of the pain being gone, being able to walk, being able to work, and the depression and anxiety alleviating, and his confidence coming back, and being able to look you in the eye and have a conversation with you. I mean, all of that has just been so rewarding. So part of what I'm trying to share with you today is that as dentists, there is so much more that you can do. And I want you to have a way that you can do it that makes you feel comfortable, that makes you feel confident. That doesn't mean that you have to spend hours and hours and hours to learn all of this stuff, because this machine does it for you. And that you can build out in your community this collaborative team. So initially, when I sent him and I send all my patients to these providers, these body workers, they initially say, well, that's what I do in my assessment. And there's a little bit of a, with all of us, right? When there's something new introduced and you think somehow it's going to threaten what you're doing, like this is kind of my world, and I do these assessments, and now you're saying that this machine in 1 minute can do what I spent years learning and practicing, and all. So there's a little bit of that. But the more that I sent with the scans, then it helped them. It helped them now to zone in and not have to take as much time, zone in right on the issue. And now I have them calling me and saying, hey, can we send somebody over for a scan? So it creates this kind of collegial, relationship with other providers in your area, that we're all just here to help the person in as holistic a way as possible. So fostering those relationships, becoming a scan center in your area, everybody that it's really cool the way that it presents. So everybody that does it starts telling their friends, and then they want to come and they want to get a scan and they want to know what's going on. So it's actually creates quite a bit of excitement in your practice, which has been fun. And the case study that I just showed you is just one example of many, many cases that we have, where understanding that point, looking at that shift, and then I always, after I do all of that, I work all my way up to the neck and the head, and then I ask them, can I look in your mouth, please? Can you open your mouth for me? And so it's a natural progression. And then when they open their mouth and I look in, and then I notice, oh, okay, yes, that explains why you're having this issue, because your tongue is completely tied, or because you've worn down your teeth, you're a bruxer, because and you just get into the conversation about dentistry. The other part of it is we can talk about breathing, because if they don't breathe well, the diaphragm is weak, the rib cage falls forward, and then you get other compensations as well, right? So it all starts to feed together. And I know that in the AACP and across dentistry, you have different providers that are really good at different areas, right? So talking about nasal breathing and well, what does it matter that I breathe through my mouth and not my nose? Well, look, this is the compensation that your body is doing because of that. So the mouth breathing creates this kind of clockwise shift in your jaw that then causes shoulders to compensate, cause the pelvis to go up. And people are just mind blown because they don't know that. Nobody's ever taught them how their body works or why they're having these issues. So how can you get started doing this in your office? Well, you just identify somebody in your office. I mean, anybody can do the scan. It's literally a click, right? So anybody can do the scan. It takes a minute. I think the longest part is putting in the patient's information. And then from there, having a conversation. You go, I'll come in, I look at that, I do a brief conversation about what it means and what we can do to help and what we need to get somebody else to help unravel for that. So you're not responsible to do all of it. And then having it be part of your records that you do. It's part of what you do for every patient that comes in, and it's included in that package. And you can track and you can do follow-ups periodically if you like. The return on the investment, I'm not going to get into that for the CE this conversation, but that's a topic we can discuss, so you can contact me. And I want to be clear that you understand that it's not classified as a medical device, it's a technology. So it's not a medical device, but it provides information that medical providers can use in their care of patients. And then ensuring ethical considerations and patients' empowerment is we give them the information. That information is free for them to do whatever they want with it. And ideally, we would have people we could recommend, but we're not required. We give it to them and it empowers them now. If they want to move forward and seek help for that, they can. But I think it is worth explaining that if you have all these other issues and I'm helping you with this, just be aware that I will be able to help you to a certain extent, but the rest of those issues may inhibit you from having a full recovery from our practice. I did put my references in here that you can review, and we create individualized training modules depending on what type of practice, what type of provider that we're working with, or a sports team or whatever. And this is how you can reach me. So thank you so much for listening, and I guess now we'll open it up for questions.
Wonderful. Thank you so much. It does look like we have some comments just saying this is great. As a neuromuscular and TMJ dentist, I know that posture and TMJs are totally connected. People asking for your contact information, which I know you shared, and we appreciate. One question, do you typically start working with spinal posture and then focus on TMD, or vice versa?
So the patients that come to me come for a variety of reasons, right? So I'm not a dental practice. So they come to me because they have, they might have Parkinson's, they have neurological issues, they have pain issues, you know, they come to me for different reasons. And I know, looking at them, I know that this is a factor. And I have spent years trying to explain that to people, how it's connected. So for me, I start with the body and I work my way up and I end here. If you're in your practice and you're dealing with TMD, headaches, and all of those types of things, then you're going to start here and you're going to say, you know, this is connected. And so this is going to be connected to your neck. And then what happens all the way down can be an issue for you. So you could do it either way. So it's not really fair for me because yeah, I'm seeing a different clientele than you are.
Is this used to replace the posture grid? And this person is currently using the posture grid for myofunctional assessments.
Mm. So the posture grid basically is just showing you a line, right? But it's not three-dimensional. It's not, you can see that the hip is up, but can you tell if it's anteriorly rotated, posterior, how much, so the body is three-dimensional. So for me, what's exciting is to be able to have something that actually shows the body in that three-dimensional form versus a grid that is just very basic. But I mean, that's what I started out with, just like everybody. And the fact that you're doing posture scanning or assessment is great. This just takes it to a whole different level.
Perfect. And then this one's a little tricky, just being mindful of the CE, but questions on like the cost of the scanning machine, and is there a training that people can go to?
Yeah, 100%. And I think if they go to my website there, they'll see all that information. And yeah, and we do training for everybody for sure.
Thank you. Does it matter where we start fixing the posture from, jaw first or feet first?
Feet first. Yeah, feet first. I mean, so let me preface that by saying you're always going to try to get somebody out of pain. If they're in pain and you can relieve that pressure and decompress the jaw, you're going to do that, right? But I wouldn't get into I wouldn't get into any big, huge, heavy duty, expensive protocol to do that. I mean, I would start with something that's like anterior bite plane or something that just kind of alleviates that pressure. And then in terms of the feet, it's as simple as maybe a little bit of a wedge or some type of orthotic type of thing in the foot, something that you can just have in your office that you could try or the patient can try. So I wouldn't let it stop you from getting them out of pain, but I would be very much aware that if you're going to be doing a huge case on somebody, just be fair with them and give them a chance to see that how their body's affecting it. And it might be that you do the records today and then you see that there's these issues, so you send them to somebody and then they come back and then you start your thing. It doesn't take long. That boy, I think that he had about 4 or 5 sessions to get to that point. If you have somebody that you're working with that really knows what they're doing, it should not take a long time to be able to sort that out.
Wonderful. Thank you so much. And there are a couple more questions on the training as well as like the articles you used in your references. So again, we'll send anyone registered for this webinar. We'll get the presentation recording sent to you within 10 to 14 business days. And again, Julia shares her contact information. So we appreciate it. That was a great presentation, lots of information, and we really appreciate you taking the time to be here and present to us.
Thank you so much. It's my pleasure.
All right, great. Well, have a good night. Thank you so much, everyone, for attending.